Well, good afternoon, everyone, or depending on where you are, it could be good morning down under or good evening. So, welcome to our 14th or 15th, I've lost count, of SADS Facebook Live community. And so, all of you out there in the Sudden Arrhythmia Death Syndrome Foundation Facebook community, welcome. Thanks for joining us. On behalf of Alice Laura, the CEO of the SADS Foundation, and her team, and the board of the SADS Foundation, I'm Mike Ackerman. Have the privilege of serving as president of the board, and I'm a genetic cardiologist at Mayo Clinic. And we're really delighted to have with us, up north of us, SADS Canada, or the Canadian SADS Foundation, and representatives from the Canadian SADS Foundation. You will notice that in the four quadrants, all of us possess only a single X chromosome. So we do lack a bit of gender diversity, but remember, we had double X represented the last 3 weeks together with Susan Etheridge, Sylvia Priori, and Georgia Brugada. So I think we're balanced, in case anybody is concerned about that out there. But guys, and this time I can say guys, Dr. Hamilton, Dr. Sanatani, and Dr. Krahn, thanks for joining us at SADS Foundation. We're going to have a great time together. So thanks, guys.
You're very welcome.
Great to be here.
Yes, thanks.
Maybe we'll start with you, Shu. Dr. Sanatani, give us a brief intro of who you are, and then I'm going to tag it Dr. Krahn and then Dr. Hamilton, and then I have a couple questions that I need to throw your way, but let our community know who's joining me today. Shu, take it away.
Well, thanks, Mike, and thanks, Alice, for this great opportunity and set up. My first disclosure, of course, is that I'm totally new to Facebook, so I'm glad that I've actually managed to stream live here. That was challenge number one. I'm a pediatric electrophysiologist in Vancouver, British Columbia, and delighted to be part of really an international group of pediatric EPs. I was the president of PACES, or the Pediatric Electrophysiology Society, a few years ago, and a very passionate inherited arrhythmia researcher. Participate in a few projects with my co-conspirators, all depicted here. So thanks for having us.
Thanks, Shu. And Dr. Andrew Krahn. Dr. Krahn's going to be president-elect, or is president-elect, of Heart Rhythm Society, but tell us, starting next May, but tell us a little bit more about you, Andrew.
Oh, thanks, Mike. It's great to be here. I appreciate the opportunity, and as the SADS Canada team knows, we've been partners and known each other for a very long time. I tease sometimes and say I run a hat store in Vancouver because I wear a bunch of different hats. As Mike said, I'm now the president-elect for the Heart Rhythm Society, and what that does for the next year is puts me in charge of next year's Heart Rhythm Society annual meeting. I'm the program chair, so that's a big project that's on my plate, and was very involved in the virtual meeting that just happened. My other hat on the national front is I'm the president of the Canadian Cardiovascular Society, so that's kept me busy with the national perspective on guiding cardiovascular care delivery of this COVID era. That is part of what we're going to talk about this morning. And the last thing is, I've been interested in this for a very long time. And I remember the two brothers I was sent to see 28 years ago to clinic when I was training, who had long QT. And the question about what their diagnosis was, what their family story was, how we could help them and try to understand and recognize and prevent sudden death. So I got a lot of reasons to be here, and I'm very grateful for the opportunity to have a nice exchange with everybody in the audience.
That's great. Thanks, Andrew. And last but certainly not least, my good friend, Dr. Robert Hamilton. Welcome, thanks, and give our community a snapshot of you, sir.
Thanks very much. I'm Bob Hamilton, and I work in Toronto at the Sick Children's Hospital. Ran the electrophysiology program here for about 14 years, and now just another one of the electrophysiologists, but have a big interest in the inherited arrhythmia clinic. And then finally, I do about 50% research, and all of my good colleagues online here today have been tremendous collaborators in making some new discoveries in the research around inherited arrhythmias.
Well, thanks to all three of you. And we all have been dealing with the COVID-19 pandemic in our own ways, and on the local scene, regional, national, and international scene. And we've crossed, as you know, 6 million cases. There's been over 300,000 lost lives in the United States. We happen to be number one, not something that we would like to win in, but we have currently the most reported cases and deaths at over 300,000 COVID-associated deaths. But when this all broke out, I'm sure your genetic heart rhythm and genetic heart disease family started to reach out to you guys with particular anxiety, particular concerns, and so forth. And as we get started together, Shu, what have been sort of the 2 or 3 most important messages or reminders that you have been giving your SADS families as they've contacted your program?
Yeah, Mike, it feels like a long time ago, but it's only been about 2.5 months that I was plunged into an uncomfortable place of complete lack of knowledge. And I think a lot of us who are used to being regarded as, content experts or, reasonable sources suddenly found ourselves in new territory. So I was grateful that the Canadian pediatric community and the Cardiology Association, they quickly decided we're gonna track cases and get data. And that's been one of the most powerful things. And I think that's been observed really internationally. Without data, we're lost. And so I've taken some comfort that we keep going back to the data and looking, how are our inherited arrhythmia patients doing? What, are there any blips? And having a global community around this, looking at the numbers, and especially with the rapidity with which this is spread, we've seen the blips relatively early. And I'm very relieved that there haven't been any blips in the inherited arrhythmia community that I've seen. So the first thing really was the data and being a collaborative community. And then, we've been very fortunate in British Columbia, and Dr. Bonnie Henry has become a household name, and her guidance, I think, around the, basically the mainstay of treatment. I think the COVID management reminds me a bit of our long QT basics. The COVID management basics are, hand hygiene, physical distancing, avoid unnecessary contacts, and stay home with symptoms. We've all repeated the long QT mantra about, take your medication, avoid QT prolonging drugs, have an action plan for your activities. So it's, we've had a bit of time to get some comfort in this.
Great. Bob, your most important message that you've been sharing with your families has been what?
Well, I guess, all that for most conditions that there isn't a big effect of COVID, but of course, in general, you just want to avoid getting COVID, to avoid passing it on to people who are at high risk, and they may not be the inherited arrhythmia community, with a few exceptions. So that's one thing. I think the other big takeaway is that it's really made us change the way we do patient care. And some of that is actually for the better. I mean, if you're just dabbling in this kind of presentation or in seeing patients by telephone or in video conference, it's very inconvenient. But when it becomes your go-to mode, you actually start to realize some of the advantages, particularly in a place like Ontario, where people are, in many cases, spread very far apart. So I think that's, we can do it. We're not quite back at full efficiency, but we're learning new ways to do things, and I think we can get there.
Great, thanks, Bob. And Andrew, from your own personal practice, your single most important message, and then maybe the hat in your hat shop of Heart Rhythm Society leadership. What, as a Heart Rhythm Society, has been sort of a singular most important message or messaging?
Yeah, good question. I think on the home front, like the other speakers have said, I think the first message when we got the usual calls and emails about, am I higher risk? Should I be going to work? What extra precautions should I take? The short answer is the vast majority of people are not particularly high risk. So the reassurance that they should take usual precautions, but they're not, shouldn't be unduly concerned. I think the second thing is there are some of our conditions where COVID has worse consequences And a good example would be Brugada and the probability of developing fever. So there's a very pragmatic thing where Brugada patients need to be hypervigilant about fever because COVID is typically accompanied by fever. So there's a sort of a hands-on tip. One of the things that we've developed in our national messaging has been is a two-part message. The first part is the tagline is emergencies are still emergencies. So this is the idea that, as you know, about half of people who would normally come to medical attention when something happens with a change in their health or they have something more dangerous than that, they're actually staying home. They're worried about COVID, about getting out into public. And so if you faint, if you have chest pain, if you have shortness of breath and other cardiovascular domains, those are reasons to come to medical attention. And the other part of that message is that hospitals and emergency rooms and clinics are safe. They have all kinds of precautions in place to make sure that if you say, I'm worried because my daughter fainted, let's take that example. There's a process to protect people from COVID so they can have that evaluated so that we don't hear about tragedies of people with warning signs that were ignored because they were worried to come to medical attention.
I think that's hugely important. And I'm just curious for the three of you, you know how anxious all of our families were with what you said, Andrew, is am I at higher risk? And I just had my first this week of all of my genetic heart rhythm and genetic heart disease patients. I've had my first two patients, both Brugada, a Brugada dad and a Brugada son, have COVID-19. Those are the only two of my entire practice that I'm aware of. And he sailed through his, he was hospitalized for his COVID-19, quite febrile, not a single blip of his Brugada substrate. But I'm curious for you guys, any of your families that you're aware of, have they come down with COVID-19? Because I think the answer has been almost zero with every one of our guests for the last 6 weeks. Andrew, how about you? Any?
Zero. Yeah, very
Bob?
good news.
No, and as a matter of fact, the hospital has had very little COVID. We became a brief outbreak for just a few days when two patients in the hospital were identified to have COVID, and then 3 staff contacted it from them. And then we've had about a dozen or so patients come through the emergency department. Just this isn't inherited arrhythmia patients, but just patients in general who have tested positive. But so the hospital has been relatively unaffected, but we have had some other major outbreaks in the adult hospitals.
Yeah. Shu, what's your number at?
Yeah, it's a whopping 0, which is good.
Yeah, I think that's fantastic news. And I think that message that we've given over the weeks has been quite calming, actually, because I think some of us remember, right, the paper that came out now, seems like forever ago, but said patients with heart disease are at much greater risk of COVID-19. And as soon as that paper came out, the phones were ringing off the hook of, is long QT syndrome heart disease? Am I at greater risk? And it took a while, but I think we're past that now to where most of our patients aren't at any greater risk than any of their classmates at school or adult mates at work. And I'm now looking at the public chat, and a lot of the SADS community has joined us, and I'm starting to recognize some of them in our new virtual relationship. So hi to those of you who joined us. And Shu, I'm going to give you the first question from Jenna. Jenna, thanks for joining us. And you had mentioned, Shu, sort of the action plan that you give your families. And she's wondering, do you recommend medical alert bracelets for children and adults? And if you do, what do you tell them to have the bracelets say?
Sure. Well, almost everything is a conversation, and it's a discussion with mom and dad and the child. And we go through the scenario. Do you need a medical alert bracelet? And if you're dealing with someone who's maybe, self-conscious about their diagnosis and they're 12 years old and they're just starting to have a little bit of autonomy, that's an easier discussion where we say, well, what's your plan if you suddenly are somewhere where you need medical help and you can't talk? And then we sort of walk them to that place. So we are very pro, not just medical alerts, but some form of notifying first responders, your your school health system, and other people that might be called upon to help you. We have an excellent clinic nurse, Connie, a shout out to her, who spends time showing them where all the emergency medical information is in their phones. So if they're not necessarily wanting the traditional bracelet, there are a couple of other options in the current era. So yes, you need a way to communicate, and then keep it simple. Long QT syndrome, medication. Usually we just write beta blocker, and then and as of course almost none of our patients with long QT have defibrillators, so that's not usually necessary, but we would put it on if they had a device.
Andrew, for your adult patients, do you have them doing bracelets?
People inquire. We sometimes tell them that it's quite reasonable. And most of the time, there isn't a lot of room for text content. So it's usually about diagnosis, and if they either have a device or they're on a medical therapy, that's then summarized. One of the practical things I do that I actually think might be as good or better in most situations is I tell patients, in our environment, people have a health card. Looks like it's actually the backside of their driver's license is their public health card. And I tell them, listen, we gladly give you our last consultation that summarizes your case. You fold it up and keep it with your health card. If you're in a car accident and for some reason you can't, are incapacitated, they'll look for your wallet or health information. And oftentimes the consultation's a fair bit more informative than a simple label on a bracelet.
Yeah, it's interesting. Over my practice, I would say half of all of my patients have chosen alert bracelets and half have not, and they have been equally satisfied. I personally have them, if they do have long QT syndrome, it's just 2 lines for my patients, Jenna. It says, long QT syndrome, shock me. Because if they're found down and collapse, if the first responder doesn't know what long QT syndrome is, they probably will have a good idea what shock me means. So I like the keep it simple. Bob, here's a question from Allison, and hi Allison, and also Katrin from Germany. Guten Tag. I recognize your name now from the last few weeks. But Allison, Bob is wondering about antihistamines and whether they're okay to take while on medicine for CPVT. Frankly, it could be medicine for long QT or any of our conditions, but they're miserable with seasonal allergies. Are you letting your patients take antihistamines? And if so, are you concerned at all about the use of those medications?
Not particularly. If they're just pure antihistamine and they're not long QT, if they have a definitive diagnosis, then I'm not aware that there's any interactions there. You want to avoid any of the kind of adrenergic agents that sometimes go in with those medications in combination medication. But for pure antihistamine and in well understood CPVT, then no.
And I think that brings us to the list, right, of the medications to avoid. And I think that's one of the things, Shu, that you and I have talked about is how, yes, we want them to know the www.crediblemeds.org hit list of medicines, but not every medicine on that list is created the same. And, the antihistamine Benadryl is on that list, but I really have almost zero concern of my patient taking Benadryl if they clinically need it. What do you do, Shu, in terms of that list of medicines, and how do you help them balance which medicines matter the most that please do not take without your permission, and which ones are on the list but you're not too concerned about them? Do you have any guide there?
Probably sound like a broken record. Everything's a conversation. We don't want people trying to figure this out on their own. I think any list that needs a whole team of experts and a website is probably more complicated than a family can process. It's certainly more complicated than I can commit to memory. So we check back to Credible Meds often. And I think, a couple of the guiding principles are be careful with polypharmacy. You're probably going to be fine if you're taking, Benadryl for your symptoms, but then if some unsuspecting person adds, an erythromycin to that for something else, suddenly you may have problems. And one of the early things, your paper on the medications in COVID came out, very early out of the gates, and the whole hydroxychloroquine, azithromycin was actually, I think, sort of a boost. So people really paid attention to polypharmacy, checking your QT, and credible meds.
Yeah, and Andrew, Mary is asking us a technology question, and you certainly have your pulse on technological advances coming our way in our field. And as especially with your leadership role in Heart Rhythm Society, and Shu and Bob from a pediatric perspective, we can take it in any direction. But one of the things Mary's asking is there anything new with respect to extracting leads when her lead or her family's lead has been recalled because it's cracked? And of course, there's issues with lead extraction, but any general comments on your sense, Andrew, on where this whole area of extraction of leads is going?
Yeah, so I did lead extraction until genetics became so interesting and important that I felt that I needed to free up the time to spend more time in inherited arrhythmia clinics. So I do have some familiarity. There has been some technology development in the area about energy systems for cutting through scar tissue, about balloon systems to try to mitigate what happens when somebody has a bad complication, tears a blood vessel or something like that. But in principle, those are small things that help the physician doing the procedure to try to make it as safe and effective as possible. The principle, though, of having a lead that's malfunctioning or not functioning and removing it still carries with it the notion of needing an invasive procedure with some small but important risks to think about if you're going to remove the system. So that takes a long conversation. I think the other thing is, if I think of this from the patient perspective, one of the loud messages the community has tried to convey is this is an expert procedure that should be done by a team of people who do it. So this is not something you want done by somebody who does it once in a while or because you need it and they're your patient. It should be done by a team of people that does this all the time. It takes lots of planning and preparation, and as you probably know, the more you prepare, the less trouble there is.
On the pediatric front, anything, Shu, you would add to what you're seeing with respect to technology? You had mentioned that most of our patients don't have ICDs, and I think that's an important message, as we've discussed, right? That most of our patients actually don't even need a defibrillator and shouldn't be getting a defibrillator. But what do you see as some of the technology advances that are intriguing you?
Well, I think, the leads are clearly an Achilles heel in our young patients. They're active, they're prone to fracture, and they have probably the highest failure rate of any medical device that we use routinely. So I'm excited that there's energy around leadless systems. But I think, the kind of technology that I'm most interested in is really still at the cellular level, the stem cell potential and the modeling. I don't think it's going to be very long before someone prints a 3D long QT heart. And those are the kinds of areas where I think we're going to find solutions, because leads and defibrillators to me are the epitome of we have a hammer, and so we're treating nails. But we'll be better in 20 years.
Andrew, hammer, nails, and sledgehammers. Follow-up thought on that?
So I think the people participating are keen on what's the latest. I think I would just add that at Heart Rhythm, one of the late-breaking clinical trials that was just presented a couple of weeks ago compared the subcutaneous ICD to the traditional transvenous ICD. And this was a European study of about 900 patients. And I think the key thing is the enrollment criteria was adults, so it doesn't apply to kids, but it was people over the age of 18. And the average age are younger people more likely to be enriched by some form of genetic condition. And it showed that the subcutaneous ICD was comparable in terms of its performance, in terms of saving lives, but also complications and surgical procedures and so on. And especially if you think about people who are likely to have their system for many, many years, there's a lot of reason to believe that should be a strong consideration in every decision if an ICD is committed to about a system for patients. So, for the people who are listening, I think that's an important thing that should come up in conversation if you're getting to that shared decision conversation about having an ICD.
I think that's great. And I think we'll leave the technology for now, just for our Facebook community. We're going to have a special session devoted exclusively to technological advances in genetic heart disease, I think next week actually, or the week thereafter. But Bob, let me turn to you for what have been, as a physician scientist, some of the challenges during these last 3 months from the standpoint of trying to advance the science, and maybe even then take a moment with sharing some of the excitement of one of your and your team's, I would say, transformational discoveries with the autoimmune antibodies in ARVC, and maybe give a thumbnail sketch of where that discovery is at in its translation to something that will matter to our patients as a test. But let's start, Bob, challenges that you've observed over these last 3 months during the COVID-19 pandemic.
Yeah, so as soon as the pandemic came out, the lab closed. We got a little bit lucky in the lab in that we were sort of in the midst of getting a paper ready, and we kind of anticipated what some of the reviewers might want, and so we actually had the data ready, even though the lab was closed. So we were able to answer the reviewers, and so that new finding that you participated in is actually now in proofs and will come out. I don't have an embargo date yet, but it'll come out in the next couple of weeks. So the lab's been closed. And as of Monday, we're allowed to open up again. And we've been all working from home. The lab's about 6 people, 7 including myself. And we've actually been quite fortunate. Most of our projects we've been able to keep working on from home, both finishing off the papers that we had data on. And it was sort of an opportunity to sit back and reflect and do more planning. And now we're ready to open up again. I guess my main technician, Dip Tendu, who is the lead on those papers. He's a real wet lab guy, so he's the one that has been really stuck at home. But he's actually my age or a little older, so we wanted to keep him pretty well protected. And he's going to start back on Tuesday. He'll be the first person back in the lab. I guess the second thing is that. Recruitment has stopped and it actually won't start for another month because what we want to avoid is too many face-to-face meetings. So we're just starting to figure out how to take consents virtually so that once we can start up again, that we can avoid that face-to-face meeting. And then the question is, whether we can have the patients go down and have a blood sample, because that's yet one more stop when they come in, and we're trying to really avoid too many stops for patients that are coming into the hospital for tests. For example, when patients come in now, if they need an ultrasound, they go to the echo room and then they stay there, and the ECG person comes to them. And then if they need somebody to examine them, then the doctor comes to them, as opposed to putting them in a waiting room with a bunch of other people. So we've really changed the way we do things. I can tell you a little bit more about the ARVC discovery and the direction that's going in, if you like.
Yeah, I think what we'll do is we have only 10 minutes left. And Bob, if I could, maybe on one of our future ones, we're going to have a research discovery exclusive session of some of the key discoveries that have been made in the last 3 to 6 months. And I'd love to have you tell us about your antibody biomarker. By that time, the embargo will be lifted on your second disease syndrome. And I think we'll do both then. I'm interested, interesting, like you said, with telehealth and what we're learning how to do with video consults. And that same knowledge we've applied at Mayo Clinic with our research subjects. So we fortunately have been able to keep everything running. We do all of our consenting by electronic consent, and then the tests get ordered. And so our study coordinator sees them virtually, electronic sign virtually, and then goes down for their blood draw. So we had a slowdown, but it slowed to a trickle, and it's very quickly ramped back up. I'm curious what your own practices are like now. 2 weeks ago at Mayo Clinic, we shifted from, I would say I was about 100% video consult 2 weeks, and before 2 weeks ago, I was probably 50-50 video consult and live. And this last week was the first week where I saw more patients, outpatients in the genetic heart rhythm clinic on campus, and then did 1 or 2 video consults each day apart from them. So it clearly has shifted. And I'm just wondering where you guys are in terms of what it's like in your community. Are you mostly video consults? Are you hybrid? Are you mostly live patients that you enter the room with the, I assume, with the masks on? We're universally masked at Mayo right now. I mask, you mask, we all mask together kind of thing. Shu, what's it like for you on Monday when you go into clinic? What will it be? Video, live, both?
So the Zoom has permeated everywhere, and so my day usually starts before I even get to work with Zoom meetings, Zoom rounds. There's people talking to me while I'm driving into work. Most of my visits are now shifting to be in person, because even the virtual health that was going on a couple of months ago, now we've opened up our stress lab. I must say that the inherited arrhythmia clinic has been one of the more difficult ones because of the principles of not filling the waiting room. When we were accustomed to having 2 or 3 kids come with mom and dad and maybe the aunt, and that still is a very nice model to do it. And the kids will run on the treadmill, maybe plus or minus an echo. So I haven't been able to get rid of the reliance on testing for a lot of these. So we're having to be creative in how we book inherited arrhythmia families, and that's slowly coming. But that's one of the last holdouts. People are working very diligently to make sure the flow is as safe as it is in our grocery, where you now have arrow markers, and if you forgot the milk, you're doing another lap. So we're getting there.
Great. Andrew, what's your day like?
Well, so the little bit of background is I used to practice in London, Ontario, and Ontario launched the telehealth network almost 20 years ago. So I was always a big advocate and fan of telehealth. And so when I moved to Vancouver, I tried to promote that. And before all of this started, we were doing about 20% of our care by telehealth. And part of that is we have a huge geographically dispersed population that we try to serve, and patients are very enthusiastic about not having to travel great distances if they don't have to. So that's gone to completely video based since COVID started, and about maybe 1 patient a week or something about the referral material or something that requires an in-person. So very much, I would say at least 90% of encounters are video based. And especially for patients that you already know, I think it really does serve their needs for the most part. And the limitation, of course, is diagnostic testing, because that's been closed to the adult world for the most part, unless it's emergent or urgent as well. And now that's reopening for us. And as a result, now we're able to get the echo and the MRI and the exercise test and those other cardiac monitors and so on.
And Bob, how about you?
Yeah, so I mean, we've gone significantly telehealth. We do it in a couple of different ways. So I still have a few leftover patients from when I was a general cardiologist who have structural heart disease. So when they come in, they go to the echo lab, and then I go and see them there, because I feel that I need to do an examination of them. And some of the incessant tachycardias where I might be worried about heart failure, then I will go and examine the patient, and of course mask on and all those kinds of things. But for the vast majority, we've been doing video conferencing or telephone. I find that I use telephone for families that I know well, where the children are young. And then I use video conferencing for the families that I don't know quite so well, particularly if it's a new consult. and also where there's a teenager or an older child that should be involved in the conversation. I just find the video conference easier to involve multiple people. So that's been the approach that we've taken, and it's actually, we used to bring patients in, they would get their test, but then they'd get their Holter put on and they'd go home. So now, since they're coming in and getting all their tests, we actually schedule their video conference a few days later so that we have all the test results back.
Well, I can't believe our time is drawing to a close, and we have 4 minutes on the counter for each of you in total. And I just wonder your parting thoughts from the perspective of the Canada SADS Foundation as to what you would want to leave the community of Facebook listeners knowing. So I'm going to do eeny, meeny, miny, mo, and start with you, Bob. What's a final thought from Canada and Canada SADS Foundation perspective?
So, as somebody that does a lot of research, I'm very appreciative and to a certain extent dependent on, patient advocacy groups, not just for getting, patient participation in research and for, in some cases, helping to fund early stages of research. But now we've, many of the research opportunities that we have actually require patient involvement right from the beginning, almost from the inception of an idea. And it's been very enjoyable to have, patient advocacy and direct patient contact and involvement in the development of our research protocols.
Andrew.
Well, Mike, as you're well aware, because you were our keynote speaker, we have a national network called the Hearts and Rhythm Organization for all of these families and care providers and researchers in this field. And COVID has eliminated our ability to have that group come together this year, which is normally in June. And you were our feature speaker and so very welcome. We are committed completely to the cause of better understanding and then developing better treatments and also to develop better care systems for families. So often, physicians and researchers have a focus on answering questions, but part of that needs to be linked to delivering better care. And so I'm going to shout out to you, Mike, because not only are you a discovery person who helps us understand things, but here you are at the coalface where people have their personal concerns, helping them to learn and understand about their conditions and how they navigate the world. So I've found this to be a really positive experience. And if I'm on the other side of this, I think it's a great service to the people who are participating to be able to answer those questions.
Great. Thanks, Andrew. And Shu, your final thoughts.
Well, thanks, Mike. I mean, the concept really is, stronger together. And, inherited heart rhythm disease, when you're first diagnosed or you're first starting out in practice, is overwhelming. And there's all these satellite, nodules everywhere. And SADS is one of the networks that brings us all together, like the internet fibers, or in the olden days the telephone or the railway, and it connects so many different centers, and it brings us together for research, for these kind of discussions, for tough cases. I missed the SADS tough cases that we've all enjoyed participating on. So it's just an essential part of our community to stay together and to do what we do better. So, thank you for your leadership and for including us in this.
Well, I really want to thank the three of you. Although all four of us, as I said at the beginning, we lack an X chromosome, but we definitely make up for it in our passion for the field, for our families that we take care of with genetic heart disease, and try to represent the topic well. So on behalf of the SADS Foundation and the SADS Facebook Live community, I really appreciate the three of you. You are the real gems in our field, and it's great to count you as not just colleagues, as fellow genetic cardiologists, but as true friends in this enterprise. And so I wish you three well, safety, stay corona-free for as long as you possibly can. And for our SADS Facebook Live community, continue to partner with us. Let us know. Reach out to Alice Laura and her team as to what topics you would enjoy having as we move into this continued coexistence with SARS-CoV-2 for quite some time. It's not going away. Maybe the topics that we need to cover need to change and shift, and let us know what's on top of mind so that we can meet your needs. And I do want to give a shout out to a future Dr. Montez. I had a chance while you guys were sharing your thoughts with Diana's comments, and she wants to be a future cardiologist. Her family has type 2 long QT syndrome. Sadly, her father passed away unexpectedly 4 years ago, and I'm sorry to read that. But she wants to join us as not just a patient with LQT2, but a future cardiologist. And all I can say is, Deanna, go for it. It is an amazing field. It's an amazing time to be in medicine, and it continues to be a sacred privilege to be counted as somebody's doctor. And so I wish you all the well, Diana, in your pursuit. And so until next time, and I think next time will be next Friday, do join us. You can go on the SADS website, www.sads.org, or if you prefer, .stopsads.org. And you'll see in the top right corner a Donate Now button, and we would love to have you choose to philanthropically partner with us in whatever way to help us continue our mission. And as many of you know who've joined us for weeks, you've been watching my granddaughter grow up, and this is her last weekend, now turned 4 months old yesterday, and she fell asleep on Grandpa's shoulder. I haven't had that experience for over 16 years now with my last child, and I got to tell you guys, it's an amazing, amazing experience that that the three of you will love as well. So, Andrew, Bob, Shu, thanks a lot. SADS Facebook community. We'll see you next Friday. Take care, everyone.
Guten Abend.